All right, thank you all for being here today, and thanks to the organizers for inviting me to give this presentation here at the PMWC. It's an honor to be here in this track with you all. So my name is Matt Goldberg. I'm a Senior Vice President of Medical at Castle Biosciences and Assistant Clinical Professor at the Icahn School of Medicine at Mount Sinai in the Department of Dermatology. By training, I'm a dermatologist and dermatopathologist, but I'm going to be speaking today about gastroenterology and an application that Castle has developed in the gastroenterology space for Barrett's esophagus in TissueCypher, and talking about how artificial intelligence can unlock clinical utility of spatialomics in this impactful disease state. I want to start first with disclaimers, with forward-looking statements and my disclosures. I'm an employee and shareholder at Castle Biosciences. So first, an introduction about who Castle is. What is Castle Biosciences? We're a diagnostic molecular laboratory company that develops proprietary laboratory-developed tests that are aimed to address areas of impactful unmet clinical needs across multiple different therapeutic domains. We have tests in gastroenterology that I'll be discussing today, as well as in dermatology, ophthalmology, and mental health. And really the goal that animates us at Castle is to address unmet clinical needs of multiple different disease states of high importance, and by leveraging technology to develop these advanced diagnostic laboratory tests and diagnostic laboratory tests, we can improve the care of patients by improving the precision of diagnostic or prognostic work that clinicians are doing for patients with these impactful conditions already across the country. So today I'll be talking about our gastroenterology test, TissueCypher, which is aimed to address an unmet clinical need for patients diagnosed with Barrett's esophagus. And focusing on Barrett's esophagus is important because it's the only known precursor for esophageal adenocarcinoma. And as many will know in the room, esophageal adenocarcinoma is a disease state with a high morbidity and mortality. And it actually has a rising incidence. It's the fastest growing incidence of solid tumors at present. And that's illustrated here by the graph on the right, where you see this rising trend of patients who are developing esophageal adenocarcinoma. And as the precursor to esophageal adenocarcinoma, the importance of identifying patients with Barrett's esophagus is growing, where if we can identify individuals who have Barrett's, it's thought to be extremely common. 1 in 17 adults in the US are thought to have Barrett's esophagus. And although the rate of developing esophageal adenocarcinoma is low, the patients who develop esophageal adenocarcinoma actually have a poor prognosis with an 80% mortality at 5 years. So the window of opportunity for inflecting this curve on the right for esophageal adenocarcinoma is identifying patients who have Barrett's esophagus at earlier time points. And then when you have identified individuals with Barrett's, can you parse the risk within individuals who've been diagnosed with Barrett's and identify those who have a high risk of progression or a low risk of progression to bring risk-aligned management strategies to the appropriate individuals in the clinic. And what's critical in this disease state is that there are interventions that gastroenterologists have access to called esophageal eradication therapy, or EET, that include modalities called radiofrequency ablation, or RFA, that are known to be very effective to eradicate Barrett's or remove Barrett's esophagus and essentially arrest the progression from Barrett's to esophageal adenocarcinoma. So the challenge that Castle is aiming to address with TissueCypher is to unpack the risk of Barrett's esophagus patients and attempt to identify those individuals who have a high risk of progression from Barrett's esophagus to high-grade dysplasia and esophageal adenocarcinoma. As a dermatopathologist by training, I have to put up a histologic image here, and so this is a cartoon for what is Barrett's esophagus. An image of the normal esophagus and the squamous epithelium of the esophagus is seen here on the left. And gastroenterologists around the country are spending a significant amount of time screening individuals who may be at risk for developing Barrett's. Historically, those with reflux disease or GERD were the only ones screened for Barrett's esophagus with an upper endoscopy, but now screening is actually expanded to be inclusive of individuals who are at risk for developing Barrett's, specifically men over the age of 50 with obesity and a history of esophageal adenocarcinoma, which are known risk factors for Barrett's. So the screening funnel has increased in gastroenterology to identify more patients with Barrett's. When you establish the diagnosis of Barrett's, you do so with pinch biopsies of the esophagus, and what you find under the microscope is intestinal metaplasia, which is depicted here on the right, where the squamous epithelium is replaced by epithelium that looks like other parts of the digestive tract here in the intestine. And pathologists look to see whether you can see the hallmarks of dysplasia, and you can identify patients who have no evidence of dysplasia or low-grade dysplasia here in the center, or on the right, high-grade dysplasia or esophageal adenocarcinoma. If you have high-grade dysplasia or cancer, this is treated surgically in multidisciplinary treatment teams, and those patients are essentially routed to aggressive therapies right away. So the window of opportunity in Barrett's is really in patients who don't have cancer at the time of their diagnosis, but rather have Barrett's with either no evidence of dysplasia up to low-grade dysplasia. Can we unpack the risk or better define the risk of which patients are likely to progress, which patients are unlikely to progress in this very impactful group of patients with Barrett's, and address the limitations of histopathology in this zone. So TissueCypher is designed to objectively evaluate multiple protein-based biomarkers in the pinch biopsies that are used to establish the diagnosis of Barrett's esophagus in the context of relevant cellular and tissue-based structures in these biopsies. And so the protein-based biomarkers that are addressed here by TissueCypher are some of the relevant drivers in esophageal adenocarcinoma. We have tumor suppressors like p53 and p16, inflammatory markers like CD68, COX2, and angiogenesis markers like HIF1 alpha, for example. And it's not just the presence, absence, or relative intensity of these markers, but also where they're located in the structure of the tissue biopsies itself. So where is the staining located in relation to the nucleus or the epithelial lining itself? And so TissueCypher is developed by extracting these features using artificial intelligence based upon these 9 protein biomarkers and these 7 cellular and tissue-based structures. And from this data set, you can actually extract multiple primary features, upwards of 200,000 primary features, and secondary features number into the millions. And from these primary and secondary features, about 13,000 candidates were evaluated, developing the locked algorithm of TissueCypher, which is based on 15 specific features that were most strongly associated with disease progression in TissueCypher's development. So TissueCypher is using artificial intelligence to identify these molecular and cellular signatures of esophageal adenocarcinoma progression to improve risk stratification for patients diagnosed with Barrett's esophagus. It leverages multiplexed immunofluorescence-based platform with these 9 biomarkers, whole slide scan imaging using AI-driven image analysis, and develops a risk stratifier, or risk classifier, which is an integer seen here on the right with a risk score, a risk class of high, intermediate, and low, and that's delivered to clinicians with a specific 5-year risk of progression to esophageal adenocarcinoma and high-grade dysplasia that's clinically actionable. The test is based on a robust literature with 14 published studies that describe the clinical validity and clinical utility of TissueCypher. And in these studies, I don't have time to kind of go over all of this data, but it demonstrates the independent prognostic ability of TissueCypher that is in addition to the prognostic ability of histopathology and the clinical features that are known for patients who are diagnosed with Barrett's esophagus. So it adds useful prognostic information to what is already known about patients' risk of progression. And TissueCypher has been recognized as an advanced diagnostic laboratory test by Medicare based on the fact that it's the first test in this disease state to identify patients who have a greater risk of progression and a lower risk of progression to esophageal adenocarcinoma. This is the strongest predictor of risk in multiple studies, and here from the pooled analysis, you can see the limitations of low-grade dysplasia to identify patients who have a higher and lower risk of progression. Low-grade dysplasia is here in the curve in orange, and non-dysplastic Barrett's is in blue, and they don't discriminate terribly much here in this graph. In contrast, TissueCypher can identify patients at a high risk of progression with an intermediate and high risk score with 7.8 and 2.7 times the risk compared to low-risk TissueCypher, producing robust discrimination between who is more likely to progress to esophageal adenocarcinoma and who is unlikely to progress to esophageal adenocarcinoma and high-grade dysplasia. The strength of this evidence has also been recognized by relevant societies in gastroenterology. I think this is highlighted in a 2022 AGA, American Gastroenterology Association's clinical practice update that recognizes TissueCypher as a molecular diagnostic tool that can be used to inform the management for patients and risk stratification for patients specifically with non-dysplastic Barrett's. So I want to talk about how non-dysplastic Barrett's is a real unmet clinical need in gastroenterology and where this AI and spatialomic technology can have clinical utility in the clinic today for patients with Barrett's esophagus. So again, here are some of the limitations of histopathology and histopathology-based risk stratification in GI. Non-dysplastic Barrett's is here on the left and low-grade dysplasia is here on the right. There is a difference in published studies between rates of progression based on histologic assessment alone. And patients with low-grade dysplasia are often routed to more aggressive treatment paradigms, either with radiofrequency ablation or faster follow-up, more frequent upper endoscopies. So 8.5% risk in 5 years was essentially enough risk to launch clinical moves for gastroenterologists to intervene sooner for these patients. In contrast, if you have no evidence of dysplasia, you're routed to surveillance in 3 to 5 years, conservative management. But these groups are treated as monoliths. They're treated as whole populations. And the question is, are all patients with non-dysplastic Barrett's, do they all share the same amount of risk of progression? And with TissueCypher, you can unpack this risk and identify a subset of individuals with a low-risk TissueCypher score who have less than half the risk of the population-based estimate for non-dysplastic Barrett's. And on the high end, you can identify a subset of patients with no histologic evidence of dysplasia for whom TissueCypher identifies a high-risk score who have a greater than low-grade dysplasia-like risk and for whom you can consider more intensive management strategies. So what I want to propose here is the clinical utility paradigm that TissueCypher introduces for gastroenterologists to more precisely risk-align their management based on a patient's actual risk of progression to high-grade dysplasia and esophageal adenocarcinoma. So instead of treating all patients with non-dysplastic Barrett's the same, essentially, routing them to 3 to 5 years between surveillance endoscopies, you can identify individuals with a low-risk TissueCypher score in whom you can essentially enforce adherence to these longer surveillance intervals of 3 to 5 years and identify a subset of patients with a high-risk TissueCypher score who have a greater than would be anticipated risk of progression than their histologic assessment would suggest, and they can be routed to esophageal eradication therapy or shorter interval surveillance to essentially identify the progression from Barrett's esophagus to high-grade dysplasia or esophageal adenocarcinoma at an earlier time point. As a clinician, I really think it's important to kind of ground this in patient stories, and this is actually 2 cases that are from the development of TissueCypher itself. And these gentlemen are indistinguishable based on their clinical and pathological features alone. They're both middle-aged gentlemen who have very similar presentations of their Barrett's esophagus. They had similar segment lengths of their Barrett's with no evidence of dysplasia histologically. And the question is, do they share the same risk? What we know from these patients is that they actually had very different disease progression courses. So the gentleman on the left was disease-free for 6.7 years, almost 7 years of disease-free survival here, whereas the gentleman on the right progressed to high-grade dysplasia before 3 years. So in 2.7 years, that's importantly before the recommended interval for return surveillance to upper endoscopy. And so the idea is, would a technology be able to differentiate between these 2 individuals whose clinical pathologic features are indistinguishable? And so TissueCypher reports include a risk curve that essentially maps a patient's TissueCypher score to their cumulative 5-year risk of progression. And what's important to kind of keep in mind is this 8.5% risk of progression, that is the low-grade dysplasia-like risk that acts as a dividing line in clinical utility or clinical actionability. And the gentleman on the left had a low-risk TissueCypher score and a report of 2.2% risk of progression over 5 years. And the gentleman on the right had a high-risk TissueCypher score and a computed 58% risk of progression within 5 years. And so these patients who have indistinguishable clinical and pathologic presentations have different molecular signatures here with the TissueCypher test, suggesting that while there may be limits in the prognostic clarity provided by histopathology in Barrett's, leveraging AI tools and spatialomics tools, you can actually use TissueCypher to identify patients who have a lower or higher risk of progression in this impactful disease state. And so in summary, I really hope that this talk has been helpful to suggest how artificial intelligence is not only kind of future thinking, right? This is not just technologies that we can leverage in the future, but I think TissueCypher represents one of the clearest examples today where there's a clinically available test that's well validated to apply to patients with an impactful condition, a precancerous condition like Barrett's esophagus, to be able to inflect their treatment based on improving risk-aligned management that uses tools to inform the management beyond what we have in histopathology alone. This is the first esophageal adenocarcinoma prognostic test that's supported by 14 peer-reviewed journals with more than 8,000 patients under study. It's the strongest predictor of progression. That's when compared to clinical and pathologic factors that do add prognostic value, but this adds independent prognostic information to inform risk-aligned management. And the results are returned to clinicians in an actionable format that fits within existing paradigms of risk stratification and risk-aligned management to inform shared decision-making with patients. to use this type of information to guide appropriate treatment plans for patients with Barrett's esophagus, with the hope of improving the care of these patients across the country. So I appreciate your attention, and with that, thank you for having me here at the conference.